study was conducted in southeastern part of Bangladesh, a sub-district called Chakuria. We conducted the study in ICDRB experimental site in 9 unions and 1 township. And the study was conducted in January 2009. And we captured about 44% of the village representatives and 44% of the village doctors and 17% of the medical representatives in that ICDRB study area. We used or employed a snowball sampling technique because of the nature of the medical representatives, because they are always on the run in the fight. And also we collected the data from ICDRB database and also from the practicing formal and informal medical providers. And we conducted the study on the medical representatives from both large and small pharmaceutical companies to see the difference in practices. Both qualitative and quantitative survey methodology was used. We have conducted a number of focus group discussions and in-depth interviews with the village doctors. And also we had a quantitative survey component to capture the information on demographic profile, training, perception and practices of respondents selected for the qualitative interviews. And we employed the standard analytic methodology and techniques like grounded theory for qualitative data analysis, and for quantitative data we of course use the standard statistical tests. To look at the education and training profile of medical representatives, we see that in our study all medical representatives had at least some college level education, and the process of recruitment varied from large pharmaceutical companies. As you can see, on an average, medical representatives had around 42 days of training, but there are some refresher training and educational sessions on new drugs ranged from none to smaller companies to one to two trainings per year to several times per month at some large pharmaceutical companies. To learn more about medications, what MRs do, they use basically the company literature, pamphlets, internet, and phone calls to company's product management department. And as you can see here, it is reflected that there are 90 medical representatives in the Chittagong region. For training, the company brings all of them to one place for a day because there are so many people, there is not enough time to get detailed information about the medication. So this is what was reflected by one of the medical providers, informal medical providers. And looking at their job duties, you can see that the pharmaceutical company medical representatives, some of them, they think that selling is not selling, selling is a knowledge gain. So that's how they think their job duties are in the informal health market. The information they provide to the medical providers, as you can see here from their reflection, the literature is in English, contains complicated words which are difficult to understand. That's what one of the informal medical provider was reflecting. And the package and package inserts are very helpful, more helpful than the literature provided by the medical representative. That's what the village doctors think. However, they think that the medical representatives are not providing, sometimes they are hiding or even prescribing or even promoting like the harmful medications, like it is reflected here that chloramphenicol is not good for children, but medical representatives do not say that. They never talk about the bad effects. In this way, medical representatives are silent killers. They kill by omission. In terms of the incentives they're offering in the drug market, you see there is a range of incentives, discounts, or providing samples, gifts, and credits. And it ranges depending on the prescribing practices of the formal and informal healthcare providers. And the gifts could be even bigger gifts like foreign trips, mostly to the graduate doctors and most popular village doctors. And you can see the reflection about the incentives here from the informal healthcare providers. The marketing strategies are two-pronged. They would like to persuade doctors to prescribe their medication, and also they would like to persuade informal providers, chemists and wholesalers, to sell their medication. They use the same literature they use for both formal and informal healthcare providers, but they provide more in-depth scientific information to formal providers. They practice, market simpler products to the informal healthcare providers like paracetamol and vitamins, and to the formal providers they market more advanced medication like cardiac medication and antibiotics. There is a more professional relationship between the graduate doctors and medical representatives, and more friendly relationship between medical representatives and village doctors. Like you can see, one of the village doctors was reflecting, if I cannot pay credit, then I buy them tea, but if they want me to give new order or medicine, then they will buy tea for me. So, who are the village doctors? Basically, they are the village doctors practicing in a small place, mostly owned by them, and you can see two of them here. This slide actually is a summary slide for comparison between the medical representatives and village doctors. As you can see here, the medical representatives are younger group, significantly lower in age compared to the village doctors. Their family size is also even smaller significantly. Income is much higher compared to the village doctors. Education level, they are more educated compared to the village doctors. And you can see here the medical representatives, they don't need an alternative source of income, whereas the village doctors, most of them, they are engaging themselves in alternative income generating activities like agriculture, shrimp, fish culture, and other sort of income generating activities. So the points for discussion and what you have seen in the previous slide, the medical representatives are the important source of pharmaceutical information for village doctors. The fact that the medical representatives are more educated and financially better off than the village doctors might strengthen their position to affect prescribing practices of village doctors. Regulating and promoting ethical promotional practices by pharmaceutical companies might aid in improving prescribing habits of village doctors. And also, as I have talked about incentives, I think this is important to outline here is incentives offered by pharmaceutical companies to medical representatives encourage aggressive promotional practices that differ for informal versus formal providers. Medical representatives may be an untapped ally in efforts to address undesirable prescribing practices in informal health sector in Bangladesh and in other low and middle income countries. And finally, regulating incentives offered by pharmaceutical companies to medical representatives may encourage more ethical drug promotional practices, mostly in the informal healthcare sector. So these are the discussions, discussion points put together. So probably we'll have time to discuss them. Thank you.